Welcome back to The Blend, a podcast brought to you by the Journal of the Dermatology Nurse Practitioners and Physician Assistants and the Dermatology Digest. In this episode, host Dr. Sonal Choudhary, director of the Integrative Dermatology and Skincare Clinic at the University of Pittsburgh Medical Center, chats with Dr. Peter Lio about probiotics and their potential role in preventing and treating eczema.
Welcome back to The Blend, where we explore integrative dermatology through an evidence-informed and deeply practical lens. Today, I'm joined by someone who truly needs no introduction in the eczema world, but I'm going to give him one anyway. Dr. Peter Lio is a board-certified dermatologist, a clinical professor of dermatology and pediatrics at Northwestern University Feinberg School of Medicine, adjunct clinical professor at Mount Sinai, and guest scientist in allergy and immunology at the University of Chicago. He's the founding director of the Chicago Integrative Eczema Center and was the founding director of the Eczema Care and Education Center at Northwestern. He has served on the Scientific Advisory Council of the National Eczema Association, is a counselor for the International Eczema Council, co-founded the AAD Integrative Dermatology Expert Resource Group, and is a deputy editor and co-founder of the Journal of Integrative Dermatology. He has delivered national and international lectures on atopic dermatitis, itch, diet, microbiome science, and integrative approaches, and has been recognized with multiple teaching and leadership awards for his work in eczema care and education. Dr. Lio, it is such an honor to have you here, especially to talk to you about probiotics and atopic dermatitis and itch, which I know is an area where you have both researched and taught extensively.
Oh my goodness. Well, thank you so much for the kind introduction, and thank you for having me. The pleasure is mine.
I will get everybody started with the first question here. So the big picture, when we talk about probiotics and atopic dermatitis, are we trying to modify the gut microbiome, the systemic inflammation, the immune tone, the itch signaling? What are we trying to target? And should we view these new probiotics on the market more as the disease modifying, option or a symptom modulating option? And in this context, I know this is a long question for you, but do you think in this context, do you think they work better based on certain eczema phenotypes?
I love it. So I think the most honest answer I could give is yes to all of the above. Like, we want to consider all of these pieces. We think and hope they're interacting with multiple ways, but truly, I think we don't know. And the analogy I often use is we can just tell the story and hear how absurd it is on its face. Imagine if I said to you, you're a physician, do antibiotics work? And you would say, I'm sorry, what do you mean? Like, yes, of course antibiotics work. And I could say, well, I tried using some penicillin against a staph infection and it didn't work. And you'd say, well, of course it didn't work, because you have to know the correct and the bacteria. You have to know its sensitivities. You have to know the antibiotic. You have to pair them correctly. You have to use the right dose, the right formulation, all of these pieces. And then I'd say, aha, but that's not what you started the discussion with. You just said, do antibiotics work? And you said, yes. So I feel like we're in that level with the probiotics. It's like, do probiotics help? Maybe, we think, probably, possibly, but there are so many variables, so many different aspects of things that we don't know. And that makes it very, very challenging at this point in time.
That answer right there is what I'm going to steal and give to probably all my integrative patients and anybody who asks me about probiotics. And my way of usually saying it is a little more, probably a little harder for people to understand sometimes when I say, they are strain specific and you need to know what you're going after and you need to have data that supports it and so on. So when you're talking to clinicians, especially, and colleagues who are not so much into this area, and sometimes I get challenged by this and they hear mixed messages. So what are some meta-analyses that say there's modest benefit, but some others say there's inconsistent data? So how do you interpret the data that's out there? Is there stronger data in children versus adults? I mean, you really, work so closely with pediatric population. And do you ever have conversations around it's better for prevention versus treatment and specific strains?
Yes. Again, all fantastic questions, and questions I think that we're all actively struggling with. I think the things I can say, let's start at the very beginning, in particular with atopic dermatitis, although I think we can make a good argument that for most chronic inflammatory skin conditions, almost by definition, we know there is some dysbiosis, that the microbiome is out of whack. And I'm speaking specifically about the cutaneous microbiome, but we know that the body is very much in sync and there are a lot of reflections. And we know that when the skin microbiome is abnormal, there's a very, very good correlation with gut microbiome dysfunction as well. So we kind of start with that piece. And then I'm happy to say that we finally have begun to fill in some of the blanks in terms of why is this causing trouble? What does it mean for this to be that way? Because is it just a correlation? Is it a side effect of having eczema? Yes, but also now we've identified specific toxins that in particular Staph aureus creates that do a whole bunch of things. It directly drives itch. We see this with this V8 protease. It literally binds to the nerve endings and causes you to feel itchy. It directly can cause mast cells to degranulate, a different toxin. There's a toxin called alpha toxin that can damage epidermal membranes. So we have barrier dysfunction, we have inflammation, we have itch being contributed to very directly by staph, not to even mention like the possibility of an actual infection. When it becomes infected in the area, of course, then there's a different immune response that also is going crazy to fight back on this pathogen. And what happens is that at the same time, we see a decrease in a lot of the healthy commensal bacteria that we need, some of which play a role in maintaining proper pH, which is really critical, right? This Marchioni's acid mantle of our skin is really critical, and it's actually fairly delicate. Like we're rough on our skin, and our skin is designed to protect us. But boy, we beat the heck out of it. You use a harsh soap that is extremely alkaline. You're out in cold weather and you sweat, and then it dries again. It's very damaging to the mantle and to the skin itself. So the bacteria take advantage of this, and we see that dysbiosis. So what does all this mean? It means that we can say for sure that this is part of the pathogenesis of the disease, and thus it makes sense if we can push back on it. If there are levers we can manipulate to get the microbiome better, it really should help. And I think we know this is true. Now comes the next big leap. And this is sort of like knowing we want to get to the moon and getting to the moon. It's a big gap. Like I think we can get there, but how do we get there? This is where everything comes into play. Part of it is that my honest opinion, and it's just an opinion, it's a belief, is that there probably is not one size fits all. Like anybody who says, I've got the probiotic for atopic dermatitis, I'm sort of automatically a little bit skeptical because I feel like what we're treating is actually fairly diverse. This is very heterogeneous. And it's very likely that we're going to, at the absolute least, need a few different strains. So maybe if we have a collection of strains, that makes a little more sense because now maybe we can overlap. But any single bacteria is probably not going to work for everybody. It might work for a bunch of people, but probably not for everybody. So that's kind of interesting. And then the second one, of course, is a lesson I learned many, many years ago. Actually, I was still in residency and we were doing, I was not directly part of it, but I was helping enroll patients. There was a study where they were looking at oral probiotics for bacteria that was abnormal from after antibiotics, right? So kind of antibiotic-driven diarrhea. And they were giving these kids the probiotics, and the FDA shut the study down. And the reason was because they did some spot checking of the probiotic preparations, and they found that they were wildly different than what was being said on the packaging. You know, such and such number of colony forming units. Some of them were basically zero. Some of them were much higher. So it was so erratic that they said, you know what, we're going to shut this down. This doesn't even make any sense. And that was a really reputable brand. Now, this was 25 years ago. But still, I think that's the second part of the leap. It's like first problem, which we still haven't solved, is can we find some bacteria for at least a given person or for some people that might help, a collection of probiotics that could help, or prebiotics, the kind of food that feeds the good bacteria, usually oligosaccharides, things like fiber that help the good guys, or some combination, pre plus pro, we call synbiotics, or postbiotics, or parabiotics. Postbiotics being the things that the bacteria make that are healthy, the parabiotics being kind of inactivated or killed bacteria that still have some factor and some effect on the skin. So all of this is part of the puzzle. That's part one. Part two is maybe even harder. Once you solve it, if you do, then you have to say, okay, is the product that I'm giving you, does it have what we're saying it has in there? Is it at the right dose? Is it stabilized properly? Can it get to its target? You know, all those pieces. So then it becomes really a delivery piece. And both of those, I would argue, are still unsolved. Now, before I forget, I just want to mention the importance you brought up about the different literatures we have. We have prevention literature, and then we have treating existent atopic dermatitis literature. And you're right, they're totally different. And they're actually different problems, different questions. They're different approaches. And the things we can say with some certainty, and I say this gently because, again, the data we have is a bit variable, as you pointed out. There's some that show an effect, some that doesn't. But I think you can make a reasonably strong assertion to say there is evidence to prevent atopic dermatitis or at least delay it. Why do I say that? Well, it's like, how do you say you prevented a disease? You check at some time point, and if they don't have it, you say, okay, I guess they don't have it. I guess they didn't get the disease. But what if they get it the next month or year? It's like, oh, well, we just delayed it. So it's actually very difficult to say prevention versus delay. So I'm always a little bit careful about that, at least delayed in the context of compared to a placebo group or a group that didn't receive treatment. We think we can do this to some degree with oral probiotic supplement. And arguably the best studies are when the mother starts taking the probiotics orally during pregnancy. And then when the baby comes out, they take the probiotic orally as well, which is really cool. And that probiotic is one particular strain, and that's Lactobacillus rhamnosus GG. It's very common. You can get it very easily. I would argue there are some quality assurance measures for some of the good brands. We can get it. So that one's that part one. Part two is where it gets even crazier. For existent atopic dermatitis, that's when we get into the Wild West. Tons of different studies, lots of heterogeneity, very difficult to even do any sort of meta-analysis because of the way they approach these, the patient populations, like you end up with a whole bunch of mess.
I am so glad you mentioned this study, because I was itching, no pun intended, to bring that up. Because I was like, well, there's that one study that definitely talks about prevention in mothers, in infants through the enteromammary path. So I think that is a good one that does give us some promise for the future. And I don't know if I ask this question in a way, if I'm repeating something here, but yeah, as a provider who really works closely with probiotics in my clinic, and I get a lot of questions from the patients, and I want to give them something evidence-based always. So then what should we hear from a new company or a new product? How should they be presenting their product so we can feel more safe and comfortable in approaching it? What are the parameters a provider can look for and be like, hey, it checks these 3 boxes or these 4 boxes, and therefore I'm willing to give it a try?
I think that is exactly the right question. And this is where it gets sticky. And this is where it becomes a little bit of a subjective piece, because what you're saying, why would you say it's subjective when we're talking about objective data? Oh, indeed, we're talking about objective data, but there is a sliding scale for when we say there's enough. How do you know you studied something enough? It's almost an evergreen thing you could say about aspirin preventing blood clots. You could say I need more data, or for cardiac prevention in general, for mortality lengthening for cardiac patients. There's been data for tens of thousands of patients, right? Maybe hundreds of thousands now with low dose aspirin in these patients. But I would argue there's still questions. There's still people who say, well, I'm not convinced, or I need more data, or even things as sort of obvious. Well, we can take a politically intense thing with vaccinations. I thought when we trained, this was sort of a solved area. Everybody kind of agreed vaccines are pretty safe and effective. Now, for our listeners who are skeptical, they are not perfectly safe or perfectly effective. I don't think anybody's ever said that, or if they have, shame on them, because we know that's not true, but they're pretty darn safe and pretty darn effective for the most part. And again, of course, we're clumping vaccines together, which is not entirely fair. But as a general concept, this was a solved problem. But now people have opened up the door, sometimes, I would argue mostly for worse, but sometimes for better, and said, wait a minute, we need to look at these data. We need more evidence. We need better, higher level. So I was trying to preface it by saying there are some people for whom there will never be enough evidence. And I often say, if you compare dermatology trials in general to things in other specialties, like if you look at cardiology, some of the studies will be international studies that have 10,000 patients in them. And our studies that get things to the FDA will have like 312. Like, it's very different. It's orders of magnitude different. But so we have to be comfortable with that to some degree. And then when we go into the integrative domain, we have to be even more comfortable with more variable data, with less rigorous data, and in part because we know there are tons of limitations. There is no big integrative dermatology funding this kind of stuff. No one's going to fund, do blueberries help with such and such problem with your rosacea? No, there's no, blueberry is not going to pay for that. Big Blueberry doesn't have that kind of money that it costs to run a real trial. So we're going to have to be comfortable. We're going to have to settle to some degree for lower evidence standards. That being said, to get to the question now, what do we look for? I think we're looking for where we do at least have some clinical evidence. And ideally, it would be pretty rigorous. It would have a placebo group. It would have a diverse population that we can actually say something about. And there are a few studies that I think really do show at least some signal. And one of the best meta-analyses, the meta-analysis is now almost a decade old, but they were able to show that a couple different studies really did seem to make a big difference. And one of the things that made a difference was mixed strains. So a couple of the studies that had mixture of strains, and that's kind of what shaped my thinking on that. Mixtures of strains seem to just do better than a lot of the single strain studies. The other piece is that we'll see specific formulations being studied, often very small, but that helps too, to some degree. If you can say to a patient, look, it's a bit of the Wild West, but this particular combination has been studied, and oftentimes I'll print the abstract for the patient so they can see what I'm talking about. And actually, it seemed to help this group of patients. So this one could be worth a try, as opposed to the entire drugstore full of other ones, and different, everybody has a favorite one and a different one out there. Some are very expensive. So I try to find something that at least fits those criteria. Now, for me, some of the ones I'm looking at, I think Lactobacillus salivarius, Lactobacillus paracasei, that combination, stuff that has those in there, that seemed to be very impressive. There was in particular a study in kids so this is below 18 years of age, that made a pretty dramatic difference for these patients. And they actually kind of studied them separately and together. And I just love those two because I feel like you can find those in some high quality probiotics, but there are other ones. And there are some newer strains that are being studied right now that I think there's some good evidence for.
That is very helpful. I actually wrote that down for myself too. Well, if we know what to offer to our patients, what kind of patients do you often pick? Who's your ideal candidate? Mild AD? Are we looking at more towards moderate to severe? Where does that probiotic kind of fit into your regimen and your conversation? Are these people who have had a lot of antibiotic exposure, maybe presenting with GI symptoms? What are your top few things there that you look for?
So I've simplified it quite a bit because I give it out across the board. So there are two supplements I basically give to every single atopic derm patient I meet. And here's the spiel I give to them. I say, we think part of the problem in this disease is that the bacteria is imbalanced on your skin and in your gut. And there are at least some studies that support giving you some oral probiotics that might actually help. And I say, here's the thing. Some of my patients, they take it for a few months and say, I don't think it did anything. Others tell me, wow, I think this made a big difference. This was part of it. And I want you to try it and tell me what you think. And then I pick something, as I say, very affordable. I'm not trying to bankrupt them, but I want them to pick something if they're comfortable doing this. And I put that there, and I'll give them some examples of brands that I know and trust, and particularly combination products that I like. And then I also talk about vitamin D. That's the other supplement that I recommend across the board. I say, many of us are low on vitamin D. If we're not truly deficient, we may be a little bit on the low end. And there are some studies that suggest an inverse correlation between disease severity of eczema and your vitamin D levels, meaning when you have low D, you're much more likely to have more severe atopic derm. Why don't I test your blood right now? I'll tell you why. Because most of the time it's normal or low normal. And the truth is, it's sometimes an expensive test. And I've had patients yell at me and say, boy, I had to pay for this test out of pocket. And it didn't change your management because you still put me on vitamin D. So I put everybody on vitamin D, and not a crazy dose. I'm not trying to put them in a dangerous domain, but I truly think many of us don't get enough sunshine. We're not outside enough. So I don't think it's a crazy thing. So vitamin D probiotic for all my patients. And then when I reassess them, I ask them about it. Now, is it a science experiment? No, because I'm changing multiple variables at once. But do I get some pretty strong opinions from patients both directions? Sure. Some patients come back and say, this is amazing. I really think these made a huge deal and a big difference. I'm going to stay on them. Perfect. Other patients say, do I have to keep taking it? I don't think it's doing anything. And my eczema is doing better. The creams are working great. I don't want to keep going. Sure. And they get to choose. But I like to empower them with the understanding of why, to be very transparent about where we're at in terms of risks and benefits and costs. And I like the idea that this is not necessarily forever, that we can try it and get a sense of what they think. And that means something to me. That's pretty powerful.
Wow, very impressive, and actually very practical. Something that we can all kind of use in our clinics. Vitamin D is simple, and probiotics a little more nuanced, like you have been describing this whole time. Let me ask you quickly about itch as well. Have you seen that there's improvement in itch independent of the rash with these probiotic usages, especially for patients who are using less of any other, higher order treatments like biologics and are mostly starting out with something more integrative, such as vitamin D and probiotics? Is the itch significantly improved as well, even if sometimes the rash is taking a while?
My sense anecdotally is that no, there is not a whole lot of direct itch improvement with the probiotics in my experience. You will get that improvement as the eczema improves overall, but to me, it seems like it's much more in lockstep together, and we won't see just the itch. I mean, obviously, we deal with some people who are truly just itchy, and for those patients, I don't usually recommend probiotics at all. Interestingly, I feel like part of the pattern, if you will, and I guess this really does address the question you're asking. when am I using it? Who am I looking at? I am looking at that constellation. I feel like there should be skin barrier dysfunction. So there should be eczematous lesions, especially patients who have had a number of infections. I kind of feel like it's a slam dunk. I'm like, we 100% know you're dysbiotic. You've had staph infections several times already. Like, we don't have to test anything. We just know. So I feel extremely comfortable there. But if somebody just said, will this help with my itch? I'm looking for itch relief. I would go down a very different path, especially if they didn't have skin findings.
Interesting. And the only reason I ask more for my, our listeners to understand why I even asked that question is because we hear so much about, the neuroimmune modulation associated in the disease eczema or in primary itch conditions as well. And a lot of the treatments are geared towards managing that connection between the immune system and the nervous system. So is a barrier component directly contributing, which makes sense that, the barrier disruption is where the skin microbiome and a probiotic and gut connection would probably align even more than it would be probably with just the nerve to immune system connection. So the change might be seen more in terms of a rash and simultaneously with the itch, but probably not just on the itch as much.
That's my guess. But if you told me you did a study and you showed that it helped with itch, honestly, I wouldn't be shocked at all. I would say, okay, all right,
Yeah.
that makes sense. Because as you say, there are so many mechanisms. This is doing a whole lot of things at once. It's not a very targeted treatment.
So the one last question that I must ask is around safety. Is these are a lot of times these are live microorganisms packed in a capsule. Not always, but sometimes they are. And so there are any risks? Are there any guardrails that you put down for your patients? Anything you ask certain patients before you advise on probiotics, like especially any immunocompromised patients, children, those who have maybe central line or have certain histamine producing strains in certain probiotics, any type of guardrails there?
Yes, I think the good news is that these are incredibly safe products as a general rule. When we look at the literature on adverse reactions from probiotics, it's pretty sparse to see anything. But like anything else, that's not zero. So there are cases where people have actually become bacteremic with the bacteria that we're putting in their mouth. I mean, it's not crazy. You could imagine. So I'm particularly paying attention if somebody is immunosuppressed seriously. Now, if they're just taking cyclosporin or methotrexate for their atopic dermatitis, I usually will have them on a probiotic as well. So I'm comfortable with that. But maybe if they have a primary immunodeficiency or if they're getting a stem cell transplant, something like that, where they're going to be deeply immunosuppressed for a long period, I would be a little bit more careful and more cautious about it. If they have a central line, that's an interesting point. I think in that case, I would probably talk to the team because, again, sometimes adding additional things, if they're very, very sick and have all sorts of stuff going on, it may not be a good idea. Histamine reactions is another thing. Some people do get diarrhea from them. That's pretty common. So if somebody is more tenuous and you start a probiotic with good intentions and now they're having watery diarrhea and it's affecting their electrolyte balance, you could get into trouble. So I think we want to make sure they're relatively stable and hardy, and we are going to tell them what to expect because it's true. Bloating, gas, diarrhea, nausea. Some patients don't tolerate it. I mean, I've given these to probably 10,000 people by now, but most patients do great. But some patients say, no, I didn't like it. I didn't care for it. I didn't feel good. And I say, trust your body, come off of that. This is not a mission critical piece, but for many people, it's helpful. For some, it does nothing. And for some, it's not a good fit.
I did say it was the last question, but I have to ask you one follow-up question on this. When people stop a probiotic, which is what I tell them as well to do, if you're getting severe GI symptoms, especially, or a bad rash on your skin, especially with the GI symptoms, I personally have always felt, as me taking a probiotic too, that there's a slight adjustment period with certain probiotics, and it's pretty random in my case, or sometimes with patients. Do you ever tell them to restart it after a little pause, or start it slower instead of taking that same amount every single day, maybe like do every other day and slowly build up on that?
I like both of those ideas. Yes. And I've done both of those things. I've had some patients, sometimes you're not sure if they're maybe have gotten sick from something else or truly got some food poisoning or are coming down with something. People say, I just feel kind of crummy. I'm like, all right, well, pause it for now. We can make sure, let's wait till you get better. And then if you're up for it, you can try it again. And sometimes I would argue the majority of time people try it again and say, oh yeah, I guess I'm fine now. It wasn't that at all. It was something else. Or if they're worried about it or having something early on with they're concerned, yeah, but start with a quarter of the dose, start with every other day. I'm very open to that because, again, we're trying to gently push things back into order. This is not something like an antibiotic where we have a very specific mission and we actually have to be careful to undertreat or to treat too long with antibiotics. With probiotics, we feel like we're just putting good guys into the mix slowly but surely.
Yes, I agree with you. I mean, the cost is sometimes high with these probiotics with a lot of the patients that I work with. So if they do choose to purchase it and start taking it and have this reaction, it can be very disappointing to them. So I try to follow up with like, hey, give it a break. Let your body adjust to it. Take your time with it and go back on it slow. Don't give up. And I think that gives them this sort of hope that, okay, this was not money fully wasted. Peter, this is so helpful. I love how you just walked this thing in a middle path. It was very helpful. It was very grounded in data. And so thank you so much for blending the science of probiotics and practicality with us. And for our listeners, we will not let Dr. Lio leave without some really, really interesting tools that his personal favorites. So we're going to come back with another episode with learning about the top 5 tools for atopic dermatitis. So stay tuned. Thank you.
Thanks, everybody.
We hope you learned a lot from this episode of The Blend. Thank you for listening. Check back soon. We're dropping a bonus episode where Doctors Choudhary and Lio weigh in on the beef tallow as skincare trend.